Thank you very much. Good evening, everybody. I think it will be an exciting session on coating balloon. I have a wonderful panel there. Antonio Colombo, Azeem Latib will be the moderator, important function. The discussion we have Praveen, Chandra, Antonio Colombo that I have already mentioned, Bernardo, Cortese, and Samir, Dani. We have a remote discussion, which is Aloke, Finn, and we have a chat master. And the first slide is just to show you what we are going to discuss. I'm Patrick Serruys, currently working in Galway, in Highland. And you see the learning objective, and at the end of the session, we will ask you if you have answered this question. We want to understand how to, within the use of sirolimus DCB in new and challenging treatment indication. Point two, to know why sirolimus-coated balloon is the ideal choice in native vessel disease treatment through a case presentation. And finally, to know what the future has in store for sirolimus-coated balloon. There are multiple upcoming studies, more exciting the one than the other, and the rationale also, and how the FDA look at the introduction of drug coating balloon, not only, of course, in Europe, but in the United States. So, Azeem, you have an important function. Can you tell about your important function?
Absolutely. So besides being the moderator, I'm also the chat master, which means we have the ability here to see your questions. If you, wherever you are in the world, please ask your questions. We'll make sure we answer them. Today's your day to get every question answered about drug-coated balloons from some of the experts in the world. So no question is too small or too silly. For those of you who want to come to the microphone, feel free to come to the microphone. We'll make sure we get your questions answered.
Very good. And then you could see, at least I can see on the screen, we have Aloke, which is in his office with multiple diploma behind him, yeah? And Aloke will give a look at the technology behind the novel sirolimus-coated balloon. Go ahead.
Great. Patrick, thank you so much for the introduction, and nice to be with you. I'm sorry I couldn't be in person, but I'll do the best I can do this from remote. Let's do a deeper dive into this sirolimus-coated balloon technology. These are my conflicts of interest. We're going to discuss in detail here this Magic Touch sirolimus-coated balloon made by Concept Medical, which we at CVPath have done a tremendous amount of work with, and I can tell you we know this technology inside and out. So what are the mechanisms of this nanolute technology? How does this sirolimus-coated balloon Magic Touch work? Well, we need to convert sirolimus into submicron sized particles. We encapsulate those submicron particles of sirolimus into a highly biocompatible drug carrier, basically a phospholipid carrier. Upon inflation of the balloon at the target site, the drug carrier with the sirolimus inside gets transferred to the vessel wall following a principle of coefficient diffusion. And then the drug basically carrier mimics body lipids and liberates sirolimus over time. The submicron sized sirolimus drug particles penetrate into the artery wall and where they cause biologic effect. And this is just a description, a depiction of that. Remember, we've got the sirolimus submicron particles, we've got the phospholipid carrier. Those are combined into this drug particle matrix, which is then directly spray coated onto the balloon surface. Now, what are the unique features? Of course, it's a nano carrier technology for delivery by this core shell component. The biomimetic carrier component, really better compatibility and acceptance in tissue because of this phospholipid carrier, which is well accepted by tissues and not toxic. And then size reduction. By reducing the size of the particles, we, of course, allow for better uptake and trackability. The encapsulation allows us to provide protection of the drug during transit, remember, to the target site so that we don't lose drug during that transit time. And, of course, we have this biophasic release. We have an initial transfer of submicron-sized carrier particles within that time of balloon inflation, and then those are released over time to cause biologic drug effect, and then good healing after that occurs. And here is how it all works. Obviously, it's a process of circumferential coating under low pressure balloon inflation. Then the balloon is carefully folded. 3 folds are taking place. And then, of course, homogeneous drug delivery due to circumferential coating takes place. And this is an example of the coating quality of the balloon. You can see a scanning electron microscopy with a high power view on the right. You can see how well and evenly coated the balloon is and how sort of even the drug distribution is. So what is required to show safety? This is a big issue with drug-coated balloons, and I think it's really one of the reasons why we have no drug-coated balloon, for instance, in the United States. We need to demonstrate a lot of things in order to allow us to convince ourselves that a technology is safe. We need successful drug transfer and permanence with acceptable healing responses, both at early and late time points. We need to evaluate the drug and the effect on the artery wall during drug presence, and then at least 1 or 2 time points after its absence to make sure that those excipient carriers do not cause vascular toxicity, which only maybe manifests when the drug is gone. And of course, in addition to this, we need to evaluate downstream organ evaluation. Did emboli occur during the balloon inflation in downstream arterial beds? Were they not supposed to occur? In the heart, did subemboli cause infarction or scarring of the heart that might be an unintended consequence of the balloon inflation? Or in the peripheral vasculature, was there evidence of emboli in the downstream skeletal muscle beds? And of course, we need to evaluate non-target organs. Was there any effect of the balloon flaking off and going to things like the kidney, the liver, et cetera, during balloon delivery? Now, for Concept Medical, this has been extensively done in multiple preclinical GLP studies. And you can see we've shown sustained sirolimus delivery to the arterial wall at the pharmacokinetic curve I show you on the left-hand upper side. We've shown histologic evidence of drug effect without toxicity, both evaluating time during the drug presence and its absence, showing no evidence of arterial wall toxicity. In addition, we've shown embolization to be minimal to none. And that has taken place not only in the coronary by troponin analysis with troponins drawn in the animals pre and post balloon inflation, showing no increase in troponin, as well as we've looked at downstream embolization, no evidence of myocardial infarction at 3 days. This is in a safety dose margin study where we used high doses of the balloon, multiple balloon inflations, no evidence of myocardial infarction or scarring at 28 days, and not all non-target organs were without emboli. So I think the safety component and the efficacy component are well laid out here. So in conclusion, the Magic Touch DCB is a unique formulation of sirolimus encapsulated in a phospholipid carrier. The drug levels of sirolimus are sustained out to 30 to 60 days, which is what is needed to cause anti-restenotic effect. We have shown successful evidence of drug effect without long-term toxicity in animal models. Minimal embolic debris are seen in downstream beds. And I think the system meets the requirements of a safe and efficacious drug-coated balloon and represents an important advance in coronary and peripheral percutaneous interventions. So with that, I'd like to thank you for your attention.
Thank you, Aloke. Yeah. So we will have the time to discuss that later on. We are going to give the floor to Antonio Colombo, which is going to move behind the lectern. And it will be about images of evidence, DCB and CAD, existing indication and new indication. Antonio.
Thank you very much, Patrick. So I'm going to show images of evidence. I have no conflicts to disclose. I prefer to say that only rare situation images make evidence. So I'm not going to claim to give you evidence by few images, but at least it will be what we call hypothesis generating. DCB existing indication, I believe we all accept that DCB should be used in stent restenosis, provided the pre-dilatation result is optimal. And I'm not going to discuss this topic because plenty of information is available. I want to make something clear from the beginning, that new generation drug-eluting stent, well implanted, are excellent tool for revascularization. But the dictum, the stent need to cover the atherosclerotic lesion, was developed at the time of short focal lesion and has been extended to long lesion and diffuse disease, without much data supporting this concept, except for covering severe dissection which impairs the flow. When optimal lesion dilatation is obtained, users of gel-coated balloons may simplify the procedure, give non-inferior long-term result, and even superior very long-term results. So I think this is very important to understand that we are not competing with stenting, we are competing with default utilization of stenting in every situation, and we are competing with the idea to cover the whole atherosclerotic lesion with a stent. Why not stenting every lesion? Stent prevent vessel remodeling. Even DS have a late loss and in some patients may promote inflammation. Some stent implants on flow dynamic and shear stress generating hyperplasia. The classical example is the ostial circumflex. Extensive stenting binds the patient to DAPT. Why we can afford not implanting a stent in every lesion, and we did not have this luxury 5 or 10 years ago. We have tools to obtain optimal lesion dilatation. We have rotablation, orbital atherectomy, lithotripsy, laser with contrast, cutting, a scoring balloon, very high pressure balloon. We have imaging and function, FFR, PDPA, to evaluate the result, and we have better antiplatelet therapy. So we are not at the time where stenting was the only device to make the lesion dilatation a good result. So the approach I propose, first determine whether the lesion needs a stent. When the lesion length is short, I say less than 15, for example, and the vessel size is over 3 millimeters, minimal effort should be made not to place a DS. Maybe 5 years from now, but at the present time, this is an accepted statement. When you need to implant a long stent, the operator should consider using a DCB. A key element in this strategy is to avoid or limit stent length, is to tolerate a dissection. A dissection is not a yes and no phenomena. There is type of dissection and type of dissection. In the old time, when we use spot stenting, we go back to 2015, a dissection was not stenting if the IVUS measurement of the true lumen at the dissection size was at least 50% of the vessel cross-sectional area, or the minimal lumen cross-sectional area was about 70-80% of the vessel cross-sectional area. And these, for people that go back, has been published in JACC in 2015. Let's give you some images. This is a diffusely diseased LAD. It's very difficult in this vessel to spot where is the lesion. There is a bifurcation, but the problem is not only the bifurcation. When we measure the DFR is 85, so it's clearly critical. We do OCT that confirms that in various spots there is a severe narrowing. Long diffuse disease, there is even involvement of the first diagonal. At this point, we do dilatation, we do functional assessment also of the diagonal, is 86. We do pre-dilatation with a long balloon. Pressure wire is left in place to measure the pressure gradient after pre-dilatation. And then, because the pressure gradient is favorable, we do DCB with a long DCB on the diagonal. And we take the same approach on the LAD, multiple pre-dilatation with long balloons up to the bifurcation. We call proper lesion preparation. Why? Because we check with OCT, or you can check with IVUS. We repeat DFR, which is now 0.92. Remember, was 85 at the beginning, and the PDPA is 1. So this is a very acceptable result, despite the presence of a dissection. At this point, we treat with 2 DCB, 1 distally and 1 more proximally, and this is the final result. Another example, another diffuse long disease LAD. These may end up in a long stent or full metal jacket. I go quickly because many of these are well known. We do pre-dilatation of the proximal lesion. There is an indentation. We need to do IVUS. We see concentric IVUS. We do lithotripsy to get a better balloon expansion, even cutting balloon, then high pressure non-compliant balloon. And then in this case, we implanted a BRS, but you can implant a metal stent in the proximal lesion, relatively short, 24 millimeter long, 3.5. The distal lesion is treated in a more conservative fashion. You see that there is a dissection. We don't jump to stent the dissection. We measure the pressure gradient, PDPA 86, FFR 77. We do better balloon dilatation. The FFR goes up to 87. The PDPA is 91. Even the angiographic result is better. The dissection is still there, but the true lumen is larger. And then we do a drug-coated balloons, do 2 drug-coated balloons inflated. And this is a 1-year result with a very nice vessel maintenance. Another example, but I skip because it's the same concept. We have some preliminary data that will be presented by Dr. Pier Pasquale tomorrow. Let me go back. These selected patients, 65 patients with lung disease, mainly of the LAD, patient with various comorbidity, with possible issues for long-term DAPT. Again, complex lesion, long lesions. As you can see, cutting balloon was used in 25%, rotablator about almost 6%, shock wave. So we are not dealing with a simple straightforward lesion. Imaging was used in 62%. And we measured in all these lesions the baseline PDPA gradient, proximal, after the lesion preparation and after the drug-coated balloon inflation. And the important is the fact that the PDPA stays stable. If the PDPA tends to decrease, then you cross over to stenting because you have recoil of the vessel wall. These are the results at 12 months. We are not claiming to get rid of restenosis. We have a 15% target lesion failure, but it's a relatively benign and simple lesion that needs to be retreated. Most of the time is not a diffuse in-stent restenosis. We have 0 stent thrombosis. Of course, out of 65, we cannot claim much, but again, 0 is definitely a comforting number. So what we have learned so far, good PDPA, I set 0.9, but again, it needs to be validated, or FFR protects against thrombosis, uncertainty regarding restenosis. Most probably restenosis is protected by adequate lumen by angio or IVUS, maybe more important. And metal-free pre-CI, I say, is the only path to allow positive vessel remodeling. All of these statements are hypothesis generating, and we need a dedicated study to prove that these statements are correct. Thank you for your attention.
Thank you, Antonio. So we are going to move to Bernardo Cortese, who are going to present a recorded case from San Carlo Clinic in Milano. Bernardo.
Thank you. Thank you, Professor Serruys. Actually, this is a normal presentation, not recorded cases, but I hope that the didactical message that we are going to send is as similar. This is my most important conflict of interest, which is regarding the use of DCB. This is my part as compared to drug-eluting stent, especially in the case of native vessel disease. So I'm going to start immediately with the first case, which was a 3-vessel disease patient with a proximal LAD, diffuse disease. So we simply prepare the lesion, then we use the magic touch 2.5 by 20, then another one for the proximal part, 3.0 by 20. Okay, and this was the result, which was okay. So there was only type A dissection, which means that we can leave the lesion like as it is without fearing any thrombotic occlusion in the future. Then the same patient, after 2 days, was rescheduled for CTO recanalization of this RCA. Then we prepared the lesion quite easily. We decided there was a diffuse disease in the distal part after the occlusion, so we used the magic touch 2.0 by 30 and then a 2.5 by 30 at the site of occlusion. This is what we found. The result was deemed inadequate after recanalization of the total occlusion, and so we decided to implant a stent, spot stenting, small one, short one, just at the site of the occlusion, and this is the final result. So when we have a diffuse disease, this is a similar message to the one that Professor Colombo just told you. We need not to think at one thing or the other one, to pave the coronary artery with metal or to use only DCB till the end. In our experience, we may use a drug-eluting stent, but just sparing the length of it, just a small stent where the dissection is there. It's a more the type B dissection or a flow-limiting dissection. This is our current strategy in complex multivessel disease patients. We have data, we have good clinical data for native vessel disease with a magic touch. This is our consecutive series of patients published a few years ago with an independent core lab adjudication, and the late lumen loss in native vessel disease was good, was 0.09, considering the very small vessel size, 2.14. I think that few drug-eluting stents are able to show this good late lumen loss in this vessel size. And then we are going on with more data with Magic Touch, ISPON Registry. The 1 year clinical follow-up, the primary endpoint will be disclosed very soon, in a few days during EuroPCR 22. This is the largest registry, prospective registry ever done on DCB. 2,123 patients have been enrolled so far in the world. The primary endpoint will be TLR at 1 year, and the patients will be followed up to 3 years. The clinical presentation of the interim analysis, I cannot disclose the final results. You may imagine why. The clinical presentation was 55% acute coronary syndrome and 45% stable coronary artery disease. Diabetes is well represented. More than 40% of the patients have diabetes, and multivessel disease is occurring in 60%. De novo lesion in this registry is quite high. It's more than 55%, more than any other registries on DCB. Instant restenosis is 46%. And I have to tell you that in the last few months of enrollment, there was an increase. 75% of the patients enrolled were native vessel disease and only 25% instant restenosis. So this is something that is showing a change in the paradigm and in the mind and the mindset of the interventional cardiologist. Predilatation was pretty high, but not as high as expected, 93%, and stenting was low, and this is a good news, was 7.5%, and I can tell you that this number is confirmed by at the end of the population. This is another case that I want to show you, a highly calcific proximal LAD, a small short occlusion in the distal part, with also a circ, which is diffusely diseased. We did an IFR for the proximal part of the LAD, which was positive, so we decided to use lithotripsy in this lesion, but unfortunately the balloon was not able to cross. Then we did the OCT just to better understand the type of calcifications, and we found this huge nodule of calcium in the proximal part of the LAD. So we had to change our strategy. We predilated, we created a little room for our future device, which was rotablation. We used a small bar, 1.5, just in order to prepare the room for IVL. IVL, we had the balloon already open, so it was still there. So we decided to use just one bar for the rotablation, and then we used the shockwave, 3.0 by 8. And this was the result after the predilatation, which was deemed okay for the proximal part of the LAD. And then, considering the high bleeding risk of this patient, we decided to go for a full DCB PCI, which was consisting in a 3.5 by 20 and a 3.0 by 20 for the proximal part of the lesion, and the Magic Touch 2.0 by 20 for the distal part. This was the result, which was acceptable. And so we were able not to use stents. And then after 3 days, we had to manage also this lesion in the same patient, which was a total occlusion more complex than the previous one. So again, we recrossed the lesion. This is not the CTO. For the CTO session, you have to go in the other room. So I go fast in this part. We recanalized, we prepared it, and we finished with just the DCB. We think that another area where we need to test this type of devices is the CTO. The CTO is a setting where the stent probably is not the best solution unless you use it just where you have the large dissection, as I said previously, because you never know, also if you do imaging, which is the real size after the reopening of the vessel. So DCB can be, just think at this possibility, can be another solution. So which is the present of this technology? The present is Transform 1 and the Transform 2 trials. Transform 1 is a novel study. Professor Serruys is co-chairman for this study. Native vessel disease, vessels up to 2.75 with an analysis of the dimension, the real dimension of the vessel done by means of OCT will be randomized at 6 centers, 6 European centers to Magic Touch and sequent please paclitaxel-coated balloons after predilatation of the lesion, so correct predilatation of the lesion. Then the primary endpoint will be non-inferiority net lumen gain during 6 months angiographic follow-up. And then we will follow up the patients for up to 1 year. The presence is also Transform 2. This study has started enrolling patients a few months ago. In this study, we are enrolling patients, again, with native vessel disease between 2.0 and 3 millimeters, so we are pushing a little bit forward to larger vessels. Lesion length allowed will be up to 40 millimeters, and follow-up will be done up to 5 years. So we want to see on the long term the real effect of this device. So we will screen the patient, we will discuss, we will propose the patient to enter the study, then we will prepare the lesion. Okay, we will check if there is any reason for excluding the patient from the study, and then we will do the randomization and then the angioplasty. If the patient has a stenosis more than 30% or a flow limit in the session, the patient will be put in an nested registry, otherwise will be randomized to Science or Magic Touch with sizes which are allowed between 2.0 and 3 millimeters. If there is no major dissection, good not flow limiting result, less than 30% stenosis, the PCI will be finished, otherwise stenting with drug-eluting stent is allowed in a Magic Touch group. Primary endpoint is clinical in this study, will be TLF at 1 year. Lesion preparation, you may understand, is of paramount importance, so we are stressing the investigators to use any type of device that they deem appropriate in order to prepare the lesions, like in the case that we have seen before. The target population of this study will be 1,325 patients. And this is the steering committee for this study, which is so important for us. So just my last 2 slides. I think I'm on time. I don't have the countdown, but I think it's okay. It's okay. First of all, I would like to invite you to the Transform 2 in-person investigator meeting. I'm underlined in person because finally we are here, which will be held tomorrow at 6:30 p.m. if you are interested into joining in the study. And finally, the present is also Eastbourne. We will present the primary endpoint, TLR at 1 year, during EuroPCR within 2 days. Thank you for your attention.
Perfectly on time, Bernardo. So what we are going to have now is a discussion also with the audience. I think that Azeem has 2 or 3 questions related maybe to the case, maybe related to the presentation of the trials. I think that we may also have a question for Aloke eventually. I think it's free. You want to start, Azeem?
Yeah, sure. So there are a couple of questions from some of our colleagues here in the room for Antonio. So Antonio, you said that when you do this strategy treating diffuse disease, you need to have an ability to tolerate a dissection. So one of the colleagues asks is, when there is a balloon dissection, do you have any tips and tricks to how do you tack that down, that dissection? Is there anything you can do to make sure it doesn't extend and become a longer dissection? What are your sort of procedural tips and tricks to deal with a dissection when you see it?
First of all, the dissection cannot be sealed with a balloon. The only device to seal a dissection is a stent. So do not assume that by doing multiple balloon inflation you will seal the dissection. By doing multiple balloon inflation you only enlarge the true lumen, facilitating sealing of the dissection after the dissection is healed. So the strategy after a dissection is to do an additional inflation with a little larger balloon. Occasionally you may extend the dissection. This does not mean that you should never implant a stent. In our experience, 10% of the time you need to implant a stent.
So one question. So when we see a dissection and we are planning that we are not putting a stent, so there are two strategies which we take usually in the cath lab. One is to do a prolonged inflation using, same size balloon or just making it a 3 minutes or a 5 minutes inflation and then see how it is. And the second is that we see that there is no major dissection, no spiral flap. But if you check these vessels, if you are doing the second vessel, maybe in 5 minutes time or 7 minutes time, you see that it is looking worse now. So that thing has to be considered. If you are leaving a dissection, maybe you watch it for 5 minutes in the cath lab and then come out.
Absolutely.
Yeah, what we have seen in Transform 1, and we will show that tomorrow in great detail, is that in the large majority of these pre-dilatation, pre-drug coating balloon, there is a fracture. I call that fracture, not dissection. There is a fracture of intima, not at the site where it's the thicker, but the thinner. And then you have this kind of dehiscence, that's more beautiful than dissection, dehiscence between the media adventitia and the intima. And the question for Aloke is maybe, do you think that it will play a role because that dissected area, the drug coating balloon is directly in contact with the media and the adventitia. Are we going to see specifically in that area some positive, some expanding remodeling? Any idea about that?
I'm concerned if you see a lot of tears and you've done a lot of tear, you torn the IEL, for instance, are you going to have a problem with exuberant restenosis? I think excluding the cases where there's significant dissection is probably wise because it complicates the interpretation of the trials if the type of dissection is not identified, like you're saying, Patrick, and the extent of the dissection.
Good. Another question from the audience?
There was another question for Antonio, and I think it goes a little bit to what Aloke is saying as well. Doing these long diffuse disease, we see now, finally, we're starting to see follow-up data from you and others of how this goes, and the clinical data looks good. But what about angiographic data? Are you guys collecting angiographic data? Maybe there's some restenoses or there's some aggressive remodeling that's happening that you don't know about. What are the plans for having angiographic data?
Absolutely, we need angiographic data because we cannot rely on anecdotal cases, but you can only do it in a prospective study. And there are a number of prospective studies going on. Next year, we will have plenty of data available.
There's a lot of questions coming here, by the way.
Maybe a question for Bernardo. The registry, when you do a registry, basically there is an educational goal. I mean, the people have to get used to the technology and feel confident about that. But do you have for the interpretation, I mean, you will have a certain percentage of maize and a certain percentage of this and that. Do you have a way, a performance index or for propensity of something to compare? Not in a randomized trial, of course, but to compare, to explain what is the value of the registry, what is maybe the type of identifying the subgroup which is going to respond better?
Yeah, this is a great point. I think that Registry can give you some information on a new device that will help you in designing new randomized clinical trials. In this case, we designed the first version of Eastbourne, which had to collect 900 patients back in 2016, before this device had the CE mark, because we thought that sirolimus should have been another important tool on top of paclitaxel for the DCB arena. We still use paclitaxel, but sirolimus has different characteristics. So this is why we designed Eastbourne. And since then, we started enrolling patients in 2017. We have designed 4 or 5 sub-studies with propensity matching, which will allow us to understand better this technology.
Dr. Serruys, taking the cue from this information which you are providing, that if there is a dissection or if there is a dehiscence of the plaque there, and then we do a drug-eluting balloon, probably the drug will go deeper and will have a better effect. So do we have any information on the data which we have that those patients who received any kind of plaque modification therapy like Scoreflex or a scoring balloon or a cutting balloon or a IVL, was there a difference in outcome between these two? We don't have that information.
No idea, too premature. But it's a very good question, because in your randomized trial, you will have, and that's smart, I think, you will have the preparation before the randomization. The question is, if you listen carefully to Antonio, he would like to optimize that preparation, to maximize that preparation, but you are prior to the randomization, so you don't know in which group the patient will end up. You will tell me, for stenting, it doesn't matter, so it's only matter for the case who are going to have. Is that your attitude of your thinking?
Well, we think that the best from this technology can be achieved only if we have taken off the large amount of plaque, because we have seen in many cases, we have plenty of cases where we prepare the lesion not correctly, and then you have recoil, maybe not immediately, but after a few weeks, and then it is a failure, because the scaffolding effect of the stent is important, we know this. But we believe that the scaffolding effect is not useful after a few weeks. Okay, so if we prepare the lesion well, there will be the perfect setting to test these two different devices.
In fact, in my experience, I can share. Can I share one more thing about this? That in those patients, especially the ostial lesions, bifurcation lesions, when we did cutting balloon or any kind of device with like scoring balloon or Scoreflex, we found the results were better, the recoil rates were lesser.
Okay, I think you just answered now one of the questions, which was about ostial lesions. So you tend to use a cutting balloon or a scoring balloon when you use ostial lesions with a drug-coated balloon?
Absolutely. Okay, because they have more fibrous tissue at that point.
And then I have 2 very quick questions, but I'm going to ask you for a quick response, please. The one, a colleague who's here is asking about elastic recoil after you use a drug-coated balloon. Is that an issue? Do you see that?
I see that, and the scoring balloon is the best solution in these cases.
Okay.
Very fast.
Thank you. And a very quick question for the trialist and for Dr. Serruys, Professor Serruys. And there's a few people asking, Patrick, about late lumen gain with sirolimus drug-coated balloons. We've not seen much data. We've seen this with paclitaxel. We have negative late loss in de novo lesions. Do we have any data, or is there plan to have data, angiographic data on this balloon?
No, tomorrow we are going to show during the symposium the data in the first 57, that's the half of the trial. What I have seen is, and all these cases have OCT at least in the acute phase to calibrate exactly your drug coating balloon, You want to have full apposition. What we have seen is basically 1/3 with positive remodeling and 2/3 with some loss. Not dramatic, I mean, the loss by memory is 0.20, which is not bad because, the stent was 0.87. The bare metal stent was a machine to create neointima, and the usual balloon was around 0.40 or 0.37. So certainly there is a limitation of the late loss. They are 1/3 of the case with clear remodeling, and the final result is that you have a net gain globally.
Good.
Yeah,
Great.
and that's what
Great
we
data.
want to have. Yeah. Okay, I think if there is no more question from
Can
the
I
audience.
ask a question to Professor
sure.
Colombo?
Yeah.
In our lab, when we see a type B dissection, which is little long and has not affected the flow, we tend to use FFR to determine whether to put a stent or not. Do you think that apart from angiographic appearance, FFR or IVUS would matter in deciding this?
But the study that will be presented tomorrow by Dr. Leone will address this issue. Instead of FFR, we use PDPA. Certainly is a reassuring element. The problem is that we do not know what is a cutoff value of FFR that protects against restenosis. I believe that you need an adequate lumen. So to me, IVUS or imaging is more adapt for this type of goal.
Patrick, there's one more question I've got to ask because I think it's a controversial one, and I'm going to ask this question to you. So one of the colleagues says, we're doing this hybrid approach now of metal with drug-coated balloons. He's saying, is this the right approach? What about rather developing better bioreabsorbable scaffolds rather than this approach? And then if this is left unrestricted, if everybody starts doing some of the cases that we see here, will this end up like what we saw with Absorb, with suboptimal results, maybe patients having acute vessel closure? I think it's an important question to address.
My last slide for tonight is basically discussing that. I mean, I think that we don't use the word hybrid because the hybrid in the nature are always dying, okay, and they don't get reproduced. We call blended, blended. Like a good whiskey, a blended whiskey.
Good wine.
So I think that Antonio will not contradict me. I mean, we are, after all, doctors. We don't have to do metallic stent only of drug-eluting stent. We can blend the technology. And clearly, you will see in the upcoming month the bioresorbable coming back, but 100 micron, of course, it's no longer the 140. So if the dream is to not cage the vessel, and why we don't want to cage the vessel? Because we want to give that freedom, In the next 10 years come the PCSK9 and the anti-Tilokin and all these things, which are going to have a serious impact on the plaque. So if it is caged and the plaque is outside the cage, you cannot expect too much. Mm-hmm. I mean, the only thing is the intima inside the stent. So I think that there will be a blended technology. I would not advise to oppose. I would go for a strategy. Yeah. Strategy.
There is no question that this strategy implies people to use angioplasty. Yeah. And many new generation interventionists never learn to do angioplasty. So it's not going to be an easy task because we have to teach something that was considered wrong.
Correct. Totally.
And just a final word of that, when you see the OCT and you see this fracture of the intima and too big, long flap, if you don't have the right character, you stand these things because you get afraid of it.
You never should do OCT after DCB.
Yeah, but I mean, we can learn a lot from DCB. I think let's assume that the volume of the dissection will be a factor of good result, and you will think differently. You
remember the classic paper of Andrea Grunzig written in 1987, where he published that the best long-term result were PTCA lesions with a dissection and a low gradient. Low gradient was good, but a dissection made the low gradient better.
And in Circulation, I made a paper of therapeutic dissection and good results.
1987.
1987. Okay, I think we are just on time. So we are going to move to Samir Dani. It's a recorded case from the Apollo Heart Institute, Ahmedabad. in India.
Good evening to all of you. And as Professor Colombo said, an image rarely makes evidence, but I am going to show you an illustrative case and then continue with the discussion. The patient in question was a young 53-year-old smoker, mildly hypertensive, iron deficiency anemia, thal-minor, having borderline sugar levels, presented with unstable angina since 4 or 5 days, had history of episode of syncope, followed by, and had on echo, no wall motion abnormality, ECG, no significant STD changes. He had no other functional assessment. His angio showed mild plaques in other vessels, and in mid-LAD, there was a lesion involving D2. As you can see, most of the vessels, most of the segments were disease-free or having mild plaques, and the lesion which interested us was in mid-LAD involving D2, near the D2 ostium. The options, interventional options, were to use a drug-eluting stent or a drug-coated balloon. The classical, the routine intervention would have been a provisional DES in the mid-LAD across the vessel, across the D2, which was like a 2 millimeter vessel, or use main branch DES and side branch DCB, or use DCB in both. We decided to go ahead with DCB in both sirolimus-coated balloon, Magic Touch. And the procedural steps were right radial access was already there, 6 French XB3 guiding catheter, 80W wire in LAD and D2. And we started with pre-dilatation with cutting balloon because this was near ostium and 011 type of situation. 2.5 by 10 Wolverine. It dilated at 14 atmosphere, and then it was not adequate. We again dilated with an NC balloon, 2.75 by 15. Then it was not adequate, and then we used 2 more cutting balloons. I'll just show you all this. This is the first 2.5 by 10 cutting balloon. And then 2.75 cutting balloon when the lesion preparation did not look adequate. The distal vessel did not appear larger than 2.75, but after repeated dilatations, it seemed that it was slightly bigger. So we went ahead, and after seeing this significant recoil, mind you, there was no waste on the balloon. We did high pressure dilatation, and then had significant recoil after a few minutes. So we withdrew the side branch wire, went in with a larger cutting balloon, 3 by 10 at 8 atmosphere. Then the 3 by 10, same cutting balloon at 10 atmosphere. And then followed by an NC balloon at 12. And then Magic Touch 3 by 25 was delivered in the main LAD, main branch at 10 atmosphere, prolonged inflation, and then after checking the result, we delivered the side branch Magic Touch 2.25 by 15, which was inflated at 8 atmosphere. And the main branch balloon pulled back to give a kissing balloon inflation. No significant recoil was observed after 5 minutes, and then we continued to observe for 10 minutes, and this was the final result. So 3 into 25 Magic Touch in LAD at 10 atmosphere for 3 minutes, 2.25 into 15 inflated at 8 atmosphere, followed by simultaneous kissing balloon inflation for 2 minutes. Same kissing balloon inflation was done again for another 1 minute, and the end result was good. So as we have discussed the potential for DCB in complex PCI, we have several potential benefits. And as far as evidences and guidelines in bifurcation PCI are concerned, bifurcation PCI presents specific challenges in terms of both not only the technical complexity in terms of the procedure and the long-term clinical outcome, which are often compromised by suboptimal side branch results in the long term. Early studies looking into the use of a bare metal stent into the main branch in combination with a drug-coated balloon in the side branch demonstrated a lower rate of lumen loss in the side branch when side branch was treated with a DCB. And in DCB-only PCI, de novo bifurcation lesions with side branch 2 millimeter or less, there were lower rates of wrist stenosis and TLR, and this approach was superior for especially Medina class 011 lesion in a small randomized trial compared with angioplasty alone. So now use of DCB in bifurcation has been accepted somewhat. It's class 2A level C recommendation in most of the societies, as you can see in the Italian society recommendation, German group recommendation, and China expert consensus. And as we have discussed, the technique is very important, and the most important step is optimal lesion preparation with proper predilatation. And once you have acceptable angiographic result, then only you go for DCB, keeping in mind that some of the DCBs require really a short delivery time and sufficient inflation time so that enough sufficient amount of drug diffuses into the media. And if you have suboptimal angiographic results, that is type C dissection or more, then you go for a stent. So DCB-only strategy for bifurcation lesions may be attempted, while a DES in main branch and DCB in side branch strategy may be chosen if there is a compromised result during the predilatation stage, so you have a kind of crossover. Decision on balloon size across a bifurcation lesion can be sometimes difficult, as is shown in this case, because we kept on increasing our balloon size to get an optimal result. Distal MB reference diameter is an important issue, and especially when the distal to proximal main branch ratio, diameter ratio is in the range of 0.75 to 1 or 1:1, then the balloon and DCB usually adequately treat the more proximal vessel if you take the balloon in terms of sizing it with the distal main branch diameter. When a strategy of treating both distal branches in 011 is chosen, one can prepare both lesions sequentially, and that is the advantage of this particular technique, and even subsequent DCB delivery is done in a similar fashion. You can do it sequentially as if you are doing one vessel at a time, and then you can have a final kissing balloon inflation in selected cases. So DCB in bifurcation compared with DES use allows kind of simplification of the procedure, as the majority of the work can be done in a sequential manner. Adequate predilatation is very important, as has been emphasized time and again by every speaker, and use of special devices, one should not shy away from using them, like cutting balloon, high pressure balloons, rotablator, or shockwave. And once you have achieved optimal predilatation, then only you commission DCB to get the result you want. Available data on the role of DCB in bifurcation treatment are still limited, undefined, and as Professor Serruys and Professor Colombo has said, this is a technique which should complement our existing angioplasty procedure using stents and whatever other devices we may choose. Thank you.
So we will have a discussion. I think that we should give the floor to the audience. We are clearly in uncharted field here. Yeah, there is basically no data. I think you have created what we could call the key-B DCB, key-B DCB, or DCB key-B, whatever you want. Okay. I think we cannot argue with the success. The end result looks fine. I would have loved to see some intravascular imaging at the different stage to see because I guess that in OCT you would have seen some circular concentric fibrotic tissue, explaining this recoil, and then you have to cut, and finally your drug coating balloon start to work. Any question from the audience?
No, not yet.
Not yet.
Yeah, so I have one question and discussion on this. Because when we have long lesions, and sometimes the long lesions can be tubular, like it's a 2.5 all the way down, but at times it will be like 3.5 tapering into a 2.5 vessel when we are treating, for example, a LAD or something like that. So in those situations, using one single balloon will not touch the vessel wall in the proximal segment. So in that kind of situation, one has to probably use two balloons rather than using one balloon.
Any other comment, Antonio?
Yeah, maybe, you showed mostly diffuse disease, this long diffuse disease. What about bifurcations? Because many people, when we talk about DCBs outside of restenosis, people always get very excited about bifurcations, saying, and there's different approaches. It could be double DCB like this with no stent at all. It could be just a DCB for the side branch.
I don't think we have at this point of knowledge to challenge stents. But in bifurcation, for example, it's a long time that I don't implant two stents in a bifurcation. You at this point, you can implant a stent in the main branch and do DCB on the side branch. Maybe it's not as elegant as your case, but it's like moving step by step. So this is the first step, and then maybe you go to a more radical approach. But implanting a 15 millimeter meta stent in a 3.5 vessel, I think it's okay. It's, the gain, we know that in 4 millimeter vessel you may not even need a drug-eluting stent.
Yeah, the point for bifurcation, we know that we have, like Patrick said earlier, we have very, very few data. We have one randomized study, the Babylon, which was not good, with paclitaxel, using the DCB in the main vessel. The problem with metal is that metal is distorting the carina. So this is the main issue. So if in the future we will be able to design a good study on just delivering drug, I will be more than happy for this, really, for this setting.
So our audience is waking up, which is great, and a couple of questions. The first one is about, again, we keep talking about lesion preparation. We want everybody to understand that's important. In restenosis, we do have a study showing that a scoring balloon is, before you use the drug-coated balloon, is better than drug-coated balloon alone. I think it's called ISA 4. What about in de novo disease? Is there any, the colleague is asking, is there an advantage of using scoring and cutting over a non-compliant balloon in de novo disease for preparing the lesion?
My impression,
Not routinely. I think not routinely. I mean, I think you also for the economics and many other reasons, if the lesion preparation is acceptable or good with a high pressure balloon, I don't see the routine need to use a cutting balloon.
Absolutely. The idea is to use the simple balloon as a first step. And then, in the past, we used to use scoring balloons for calcific lesions. Now, I think we should avoid this strategy for calcific lesions. We have IVL, we have ROTA, we have other strategies. So in my impression, this case was very good, very didactical, because there was a truly, totally fibrotic lesion, even if you didn't do imaging, but probably it was totally fibrotic, no calcific lesion. And there, when you fail, so as a second or third step, you use a scoring balloon. That is the indication for de novo.
Yeah, I think we saw an advantage, with restenosis, because intimal hyperplasia and new atherosclerosis is different. You want to create cracks in the plaque, maybe in the new atherosclerosis, or in the intimal hyperplasia, it's fibrotic tissue to get the drug in. But I think in de novo disease is different. The last question, because the colleague asked me, can you do kissing with two drug-coated balloons, or you should do one at a time?
Theoretically, you can do, but we do it one at a time, because of the simple reason that when you want to do a kissing balloon with drug-coated balloon, you have to be extremely fast. In our lab, generally, we try to deliver the drug-coated balloon into the lesion. The time taken should be less than 45 seconds. From the moment the balloon catheter is introduced into your tuberosity till it is inflated. And if you want to do this fast, kissing balloon inflation with drug-coated balloon, sometimes you may fail. And then it's very important to deliver the drug properly rather than do kissing balloon inflation with 2 drug-coated balloons.
In fact, the idea behind this is that when we are doing the side-by-side inflation, one after another, the point is that you are again putting the balloon in the site where drug has already been delivered. So I have, in my practice, what I do is this, that I do simultaneous drug-eluting balloons, and I've done many instant stenosis also, especially for the left main, when they have stenosis going into both LAD and circumflex.
Okay, we are perfectly on time. That was basically a discussion on the case presented by Samir. Now we have some kind of more general discussion. I mean, we have seen Transform 1, Titan, Ginger, the IDE study in the United States. So is there something that we would like to have a discussion on that? I mean, Aloke, you are listed here as leading the discussion. There are, I tell you, some backup slide on the different trial. I don't know if we want to use it, but we have obviously some time to discuss this trial. Do you want that I start by showing something on Transform 1?
I have some questions for you. How about that? So first question, Transform 1 is paclitaxel balloon versus sirolimus-coated balloon. Did you think about measuring? I didn't see anything in the trial designs of these 2 trials looking at potential for distal emboli, periprocedural MI effects. That applies to both Transform 1 and Transform 2. In addition, Transform 2, I'm going to give you a lot of questions. Transform 2, what is the non-inferiority margin you chose? Is it a non-inferiority trial, or how did you design the statistics behind Transform 2 comparing EES to DCB?
I think the first question is very easy to answer. I want to be blind and remain blind until the very end. Okay, so I said to the core lab, don't ask what has been used, and because then you could have at some point a bias. Of course, whenever the so-called code is broken, we will look at all these issues. What is very good is that we are using different QFR system. We use the QFR system with 2 views, but also with the single view of Dr. Tu, which is providing fractal flow analysis, and then look at what he called the micro FFR, which is basically Murray-based fractal flow. And we are also looking at the IMR. So the IMR maybe will give us, in some individual, a signal that the IMR make a jump after the treatment of drug-coating balloon. And the IMR is a marker, is an index for the microvasculature resistance. So that's the answer question. I mean, but I'm still completely, the core lab, I give strict instruction, be blind and remain blind. They like that, So your second question?
For Transform 2, the question is, oh, sorry, you want to reply to Patrick?
No. Then I have another question. Answer my second question, though. Thank you.
Yeah. We had a lot of discussions with our statistical team for deciding what would be the TLF. So we used the Spirit 5 one-year data, which showed 8.1%. So we kept that for the science, for the EES group as a TLF. And then we worked a lot on the non-inferiority margins, because in the beginning they were 2.5%, which was not so high but not so low, and so then we downsized it to 1.5. So this is why this is a very ambitious study. 1.5 is very low, but hopefully we will get the goal.
Another question I have for you all is, in these trials, plaque morphology. You have any exclusion criteria for heavily calcified lesions? What type of lesions or what type of morphologies should be acceptable in these type of randomized trials and which should not, because we do know from the peripheral vasculature, the more the calcium, the less affected the DCB.
Yeah.
And so, lesion preparation and calcification could complicate the interpretation of these trials.
Maybe I can try on that one, yeah. I think what we have seen with OCT quite systematically, we have to finish the trial and review all the data, that the fracture of the intima is at the thin part of the intima, not at the big one. And in the big one, you have sometimes the calcium there, which is working as leverage for breaking the intima on the other side. So that's the kind of pattern that we are seeing more and more. The second thing that we use the machine learning for the OCT that Tu has published in CCI some times ago. It's not perfect, but it's really fast. That's the big advantage, so clinically. And then we are using some very sophisticated optical signal analysis of backscattering and attenuation, but I don't have the slightest idea what I see there, So we will need some anatomopathology in perfusion system, and we are working on that to see what is this signal. It's much more complex. Obviously, there are multiple layers in these lesions, but the significance, the prognostic value, the predictive value, that will take some time to figure out that, yeah?
Yeah, your question begs the issue of atherectomy and whether or not in some lesions, atherectomy should be performed regardless, depending on calcification level before DCB.
You're triggering a reaction of Antonio Colombo. I think that that's now 7 years that he's talking about atherectomy followed by drug-coating balloon. True?
In atherectomy, hot ablation is not really called defined atherectomy. Even orbital atherectomy is a funny word to define atherectomy. The real atherectomy is DCA, directional. But in the old time, the problem of atherectomy is the negative remodeling as a follow-up. So having a drug that we didn't have in the past in the arterial wall may prevent this negative remodeling. This is the reason why we are not going back to the past. We are going back to the past by giving means for the future, that a drug to prevent negative remodeling, because healing is always scarring and producing negative remodeling.
Yeah, I think that's really an interesting field. I mean, some months ago, we were intensively discussing that by phone. And, we called John Simpson. Yeah, but John is no longer working on atherectomy. He's working on total occlusion and re-entry, so it was not very useful. In Japan, you have atherectomy, still doing that. I mean, so that's maybe the field where we should work with the Japanese to combine the atherectomy and the drug-coating balloon. But for me, it makes somewhat sense, You remove the plaque and you block the remodeling, the constrictive remodeling. That's what you have to do. And the constrictive remodeling, it's something that goes for 3 months, maximum 4 months. I know that very well because I put patients on the table in the early day after 1 month, 2 months, 3 months, and 4 months. And after that, the loss doesn't increase anymore. It stopped. The process is stopped.
I have a question for Aloke, if it's possible. Aloke, how is you remember we had a discussion during CRT 3 months ago on the status of DCB approval for coronary, and so also Azeem may help us
in the United States.
In the US. So how is the status? Can you tell us something about the status of approval for the next few years?
Azeem, you want to go ahead, or you want me to just
go? I'll go ahead. So, let me just say by the fact that, I've been lucky to work in Europe and in the US, and I often think about the differences about working in the two countries and, what things I use in the cath lab here when I worked in Europe versus the US. I have to tell you that the thing I miss the most about working in the US is not having a drug-coated balloon. There's so many other things I would give up in the US, but not having a drug-coated balloon is a huge limitation in the US. When we need a drug-coated balloon for someone who's had multiple restenosis, you know what we have to do? You have to hope it's very proximal, very straight. You put a 7 French guide up, and you try and put a peripheral drug-coated balloon into the coronary. Okay, that's how bad it is. So we really need them. What's the current status is that Boston Scientific have a large IDE trial that's underway right now. It'll probably complete in the next few months, in about 3 months. It's one of the first trials I've seen that is enrolling faster than expected. The company made their projection, and the trial's actually enrolling faster than that. It almost never happens, right? It's a randomized study in restenosis comparing agent to POBA, because there is no gold standard in the US for restenosis. So that will give us the first device that's approved. But you know, we're here to talk about sirolimus balloons. The company does have 2 studies planned for the United States. The first one is called the Magical ISR study. I love the name, Magical. Hopefully the technology is going to be magical in ISR. It's an interesting study because I don't think anybody's done a study like this before to get approval in the United States. Because what we're going to do is we're going to randomize 150 patients only. You may say it's very few patients, but we're going to use an OCT endpoint. Right? Because using OCT, we can really measure near-intimal volume. And that will allow us to really show efficacy. Because if you can show efficacy with near-intimal volume using a drug-coated balloon, there'll be no doubt. It'll be followed by an in-stent restenosis registry, which I think Antonio is one of the PIs for as well, which we will follow it then with a larger registry single arm, just to also then enough data to show safety. Because obviously for the FDA, they want to see both efficacy and safety.
So if I ask you an year, which year? 2025? For the first DCB used outside of
I think the first coronary DCB will be approved 2023. Late 2023, next year, because the study will finish soon. They're actually doing an interim analysis right now of the study data, which will tell them what it's going to be like. It's all a question of FDA. I think it's probably going to be Q4 2023, latest early 2024. What do you think, Aloke?
I agree with you on agent. Can you hear me?
Yeah.
I agree with you on agent 223 late into 224, and I would say to Bernardo that getting these IDEs, getting the permission to start the clinical study is a significant undertaking. And really the FDA is much more changed their standards, I think, after the debacle with the paclitaxel balloons in the periphery. And there are a lot of safety tests you need to perform in order to get into clinical trials. So I would tell you that Concept Medical, I believe, is very close. And I suspect Azeem may know better than me, within the next year we'll be launching this trial.
Yep. But you know, it's gone from what Aloke says is true. The FDA has put such high regulations. We've gone from there being no randomized studies. Within the next 2 years, there'll be 5 because Sequent Please will have a randomized study, Med-Alliance will have a randomized study, and Medtronic will have a randomized study. And part of the interest, I mean, just out of interest for why there's, you know, I think the FDA has made it easier, but also from a reimbursement point of view, it's going to be very interesting. Remind me again, what do you pay for a drug-eluting stent in Italy?
180, 150.
He probably pays a little bit less, Antonio, but I mean, it's in that range, right? We're starting to talk about €100. In the US, drug-eluting stents still about $800 in most centers. The first DCB that gets approved will be the first device other than brachytherapy approved for in-stent restenosis. So they're trying to figure out what it's going to cost, but I suspect it could be anything between $1,500 to $2,500 a DCB.
Yeah. Oh my God.
So don't come to the US.
You can follow the example of China, where the drug coating balloon is 3 times more expensive than the stent. Yeah,
absolutely. It'll be the same in the US.
One important point is not to call all drug-coated balloons. I think at this time we have to define which drug-coated balloon we are using, and the results are only pertinent to that specific balloon.
No class effect.
We are not In the drug-eluting stent, we are almost close to a class effect. Just give me a DES. I do not believe we are ready to say just give me a DCB.
Yeah.
So the expression was always, they are equal, but some are more equal. Yeah?
The price of drug-coated balloon, let me just tell you, in India we have been using it for the last many years. And the price to the final price is about $2,000.
Oh, wow.
No, not 2,000. I think it will be about $1,000.
About 1,000.
About 1,000.
And a drug-eluting stent to put
Stents
it into?
are very less. They're like $300. $300.
So 3 times the price.
300 to 400.
Yeah. Wow.
Yeah, because that is regulated.
I think that the FDA is also quite sensitive to unmet need. Yeah? Instant restenosis, you don't want to put another layer of metal. I think that's good. I think everybody get slowly but surely exhausted here now. Yeah. More questions?
No, we've done all the questions from the audience.
So I see that we are on time. I see that I have the privilege of the duty to close the session. I think I have a few slides just to stimulate Antonio, you need to be stimulated. Yeah. Okay, we get that here. So just as a good anchorman, I would like to summarize what has been said. I think if you listen carefully to Antonio Colombo, he said a good PDPA, 0.9 of FFR, protect against thrombosis, uncertainty regarding restenosis. If you disagree with your conclusion, tell me. Adequate lumen by angio of IVUS may be important for long-term result after DCB. We will certainly get the answer from Transform 1 because we have a very careful quantification of the amount of space created by the dissection. Use of new generation bioresorbable scaffold will allow a metal-free PCI. That's the whole dream, which come back partially. I think you should not exclude bioresorbable from the equation. It might be what we call a good blended mixture. Metal-free PCI is the only path to long-term positive vessel remodeling. I would say be aware that very, very powerful drugs are coming in this decade. You can be sure that we will have another courage of ischemia at the horizon. I mean, I'm sure that somebody will say, let's do now with PCSK9 and et cetera, et cetera. These statements and this presentation are hypothesis generating. I could not resist to set that quoting. Is so careful. And I see the need for a dedicated study that's very clear. Aloke, say magic touch DCB is a unique formation of sirolimus encapsulated into a phospholipid drug carrier. That's an original technology. If you look at the literature, I mean, the first paper on that is 2013 with Pedro Lemos and Renu Vermani and myself and others. Successful drug levels of sirolimus as sustained out 30, 60 days in animal models. And I told you the remodeling, the constrictive remodeling is something for 90 days, but no more than that. Successful evidence of drug effect without long-term toxicity in animal model is a clear advantage and should reassure the FDA. Minimal embolic debris are seen in downstream bed. You have heard the question addressed to me by Aloke. He would like to know, and I said I want to stay blind until the very end. And this system meets the requirement of a safe and efficacious drug-coated balloon and represent an important advance in coronary and peripheral percutaneous intervention. Dani shows something new. I mean, uncharted field. DCB in bifurcation treatment are very limited data, but should be explored. I think it's good to mention that. And there is a need, of course, for targeted clinical trial. But he also concludes that promising data for additional indication have been reported in the treatment of side branch, imbifurcation lesion, de novo lesion in small vessel, MI, and de novo lesion in peripheral PTA. And I could not resist I was asked to say what is the next step in the clinical trial. There are so many options. I mean, we talk already about the combination of atherectomy and drug coating balloon. Of course, like with stent, of course, like valve, you will have, of course, magic touch versus solution and these kind of things, sirolimus versus sirolimus, not sirolimus versus taxus, but sirolimus versus sirolimus. It will take place for sure. You may have at some point company tempted by DCB versus BRS could come. DCB with OCT guidance, I think that that's now possible. I mean, Aloke said what about the quality of the tissue? Don't forget that with the OCT, you can get the OFR and the tissue composition. We certainly will learn a lot and see what is the good case for that technology. And DCB followed by aggressive pharmacological treatment, that's the way to go because you don't have the cage, so you should do. So that's a little bit the idea. Having said that, I thank you, the panel. I thank you, all the people in the audience who have asked questions and stayed to the very end. Thank you very much.